So welcome to Grand Rounds. Thank you all for coming. I'm very excited to introduce our speaker today. As part of the Grand Rounds Committee, as we brainstorm about ideas for topics and so on, one thing that we were all very interested in is really understanding other healthcare systems throughout the world, and are fortunate to have an expert in European healthcare systems in our midst. So I want to introduce Richard Saltman, who's a professor of health policy and management at the Rollins School of Public Health. He earned his PhD in political science at Stanford and was on faculty at the University of Massachusetts Amherst. I'm compressing a really big CV into a few words here. Before coming to Emory in 1991. He is a co-founder and was the long-term research director of the European Observatory on Health Systems and Policies in Brussels. He was the co-founder and long-term co-director of the Swedish Forum for Health Policy in Stockholm. And he's consulted widely for the WHO, the OECD, and the World Bank, as well as many European governments. His research focuses on the structure and behavior of European healthcare systems, including reforms in primary healthcare, decentralization, social health insurance systems in Europe, the impact of slower economic growth on national health policymaking, and the expanding role of patients' responsibility in health services. He has published 24 books, over 150 articles and book chapters, has twice won the European Healthcare Management Association's annual prize for the best publication in health policy and management in Europe, and there are many, many other honors that I will not tell you about this afternoon. So the title of his presentation, as you can see, is Current Health Policy Trends in European Healthcare Systems, and I am delighted to introduce Dr. Saltman.
Thank you, Wendy, for that very fulsome introduction. I suspect that what you will think when we get through with the presentation is there's a lot more that I'm still not telling you, because in fact it's an area that is a very expansive one. I generally say that I'm a student of the behavior and the misbehavior of healthcare systems, and that opens up the door to a wide range of activity. What I'm going to try and do in 40 minutes is to do three things, time allowing. The first is to set out a relatively quick three-part framework for thinking conceptually about health systems and how they differ from each other, the way in which they are situated in their environment and how that influences what happens and what your options are, as you'll see as we move through it. So that's the first part. The second part is I'll say something about current issues and continuing problems, primarily focusing on issues around quality, around access, around outcomes, topics which are not new for the group of countries that I'm going to talk about, and which continue through the current period. Subsequently, as part of that discussion, I'll then talk about some of the reforms that countries have put in place, the way in which they have sought to restructure aspects of their system in order to improve incrementally, if not resolve, some of the problems that they confront. And you'll see some patterns there, and we'll talk about the patterns in terms of what countries are doing. And the third part of the presentation, if there's time, and if I move quickly through my slides, will be to talk about specifically how some new reform mechanisms have been put in place to try and deal with chronically ill elderly, basically to get the chronically ill elderly out of emergency rooms and out of inpatient services as long as possible, and the way in which a number of countries have either already have or are beginning to restructure their services to do this. Although the title doesn't quite say it, the title that originally was put on the presentation does. I'm going to talk mostly about Northern European tax-funded health systems. That means the 4 Nordic countries, England, Ireland. I'll also occasionally throw in something about the Netherlands. The Netherlands is not a tax-funded system. It's a social health insurance funded system. Social health insurance means that almost all the revenues come from employees and employers, or now in both Netherlands and Germany, come from individuals and employers in a matched fashion, sort of like Social Security works in the United States. But that's quite different for a whole variety of reasons from the tax-funded systems. And the tax-funded systems are where I have spent a good deal of my time doing research. So that's what we will move into. First, the structural considerations, thinking about a conceptual language. There are three main facets that are essential in order to place a country's system in the environment within which it operates, and which also constrain options on policy size, on the policy side. The first of the three is this whole issue of the context that the country and the health system, that the country creates for the health system, perhaps, if you will. Geography, critical. If you look at the one of the key issues in a lot of European countries, not just the Nordic countries, about closing smaller hospitals, what the British used to call cottage hospitals, trying to consolidate, both for efficiency but also for higher quality. You can see between Denmark and Norway a difference in geography that has a consequence for the way that the policy has been implemented. Denmark is a relatively small, relatively contiguous country. You can drive across it in 4, maybe 5 hours. They successfully closed most of their smaller hospitals, consolidated them into bigger institutions. Norway, which has a very different geography, if you recall, there are the saw-toothed outcroppings out into the fjords where there are towns and sometimes cities out, and it's a very large, expansive geography to the north. They haven't been able to close their smaller hospitals for all of the reasons that you can anticipate, not only politically, but also just in terms of access to care. So the question about how one structures one hospitals, if one looks at a text that says, aha, the Danes have consolidated, that's good. The Norwegians have not consolidated, that's bad. Not taking into account the context, in this case geographical. There are historical issues that run through countries in terms of how institutions are organized and what that means. All kinds of political issues. Economy inevitably comes into this in terms of the capacity. There's social issues. Finland has a small Swedish population, about 6% along the coast, and they like their own institutions. There's considerable tension. You would never perhaps realize it to look at the U.S. media, between the Swedish population and the Finnish-speaking population. That comes from 1,000 years of history, back when Finland was a province of Sweden. And the upshot is that to keep things on an even keel politically, the Swedes have to have some of their own institutions, so that affects the way in which decisions get made. Obviously, demographic issues get involved. So that's one whole set of questions that set a framework for thinking about health systems, the context. Second issue that gets involved is the whole question of norms and values, the different way that different populations, different national groupings think about who they are and how that should influence their health system. What one sees when one looks across countries is that there are, for example, different ways in dealing with the question about whether or not politicians should directly run the health system, whether they should directly run the hospitals, whether they should be responsible for delivering care. If you look at England, the answer is yep, and it should be done by the national politicians. If you look at Sweden, the answer is, well, yes, but not the national politicians. It should be done by regional politicians at the county level. If you look at Germany, the answer is no, the national politicians shouldn't be involved. The system should be run by private, not-for-profit associations really, of sick funds, what are called sickness funds, associations of doctors, various groups that live in the private not-for-profit sector. And those are just understandings. Those are essentially cultural understandings, and those influence the way in which systems and reform occur. We can talk about each one of these points. The third, obviously, because they all reflect differences amongst countries. The third and last of the three different dimensions in terms of understanding conceptually has to do with the existing institutions, the notion of path dependency. If you have a unitary parliamentary structure of government, it's quite different than if you have a federal structure of government, for example. There are obviously the differences between tax funding and social insurance funding. And while there are some academics in Europe who like to argue that those two types of funding are, and the systems they represent are getting more similar to each other, they still are fundamentally different. They represent an institutional framework that's very hard to change. Ireland thought in 2011 that it was going to move from a tax-funded system to a social health insurance-funded system. By 2014, they decided, no, that was just too much. It wasn't possible to shift the institutions. And also there were some other political and social issues involved as well. So that third dimension, the institutional context, is by and large set. That doesn't mean there isn't adjustment, and as you'll see, reforms, but it's within that broader context. If you look at systems in terms of what's happened in the last 30 years, they all have differing rates of change on a wide range of different issues. All of the issues around information technology. Every country now says it has innovation groups, but in fact, the level of innovation in different countries is quite different depending on where you are in the system, what's happening. Changes in citizen expectations. One of the big, I don't know if I want to go so far as to call it a battle, but one of the 30-year continuing issues that still is not resolved adequately in most of the tax-funded countries is something that may strike you as rather surprising. It's patient choice of where they get their primary care and choice of what hospital they go to. Even when they do have choice of hospital, which has been part of major reforms that were put in place in, I guess, all the tax-funded countries in Northern Europe, still not allowed to choose their physician. That is only for those who have private insurance. So and these changes have taken far more time than you would imagine, and have also been very politically fraught. Starting in 1991, one of the sitting governments, national government, tried to legislate the ability of individual citizens to choose inside the health centers, which they were required to go to, their own physician inside the health center. That lasted 2 years and mostly disappeared, faded away. There were a couple of other initiatives. It wasn't until 2010, almost 20 years later, before, in fact, private general practitioners were put on the same footing with the health centers. And what was very interesting is that inside of 12 months, 50% of all primary care visits moved out of the health centers to the private GPs. Many of the private GPs had worked in the health centers and then had moved out with the change of legislation to set up their own practices. So you see the dilemmas, and I'm just picking out two issues. Change in payment systems, obviously all kinds of issues around provider configuration. All those dimensions, all of the components around the issues of context, the issues of culture, the issues of institutions, they set the framework when someone comes out and says to you, aha, in this country they're doing X, why don't we do X in our country, or the equivalent of X in our country? If you want to talk about relative efficiency or effectiveness, you want to talk about relative issues of cost and access, you want to talk about outcomes, you want to talk about values. You're doing it with pieces that are differently configured. They are not the same. So with that as an introduction, then what I want to do is to say something about what some of the current issues are, what some of the key problems are, and I'll divide it up into two components. One has to do with cost, and the other has to do with efficient or changes to create efficiency in the system. And then I'm going to say something about some of the reforms that have been put in place to try and deal with it. I've already said in terms of dealing with tax-funded systems in Northern Europe, there also are 4 on the southern Mediterranean tier. They're funded by a mix of national, regional, local taxes, generally around 11 or 12% of GDP. Hospitals in tax-funded systems are almost always public hospitals, typically operated by one or another level of political decision makers. The specialists in the hospitals, what are called consultants in England, but hospital physicians are typically public sector employees. Primary care physicians, with the exception of places like Sweden and Finland and a few other outliers, primary care physicians tend to be private general practitioners. If you look across the Northern European systems, what you basically see on a clinical side is that while their outcomes are good, they aren't great. They aren't as good as what some of the social health insurance systems, Germany, Switzerland, are able to achieve, particularly in areas of cancer. Cancer is an area that is constantly changing clinically, and cancer is an area where all the tax-funded health systems have had constant struggles and regular difficulties with patient associations of cancer patients trying to get them to change their policy over the last 30 years. And that continues to this day in most of the Northern European countries. In terms of thinking about recent issues, what are concerns? If you look at the English National Health Service, they in fact spend now the same as most of the European, or close to the European average. It was true 20 years ago they didn't, but they do now. In terms of quality, there are issues that show up having to do with the inability to implement keyhole surgery, as one example, because of the capital investment that's involved in that. It also involves change of routine. And the tax-funded hospitals typically have difficulty when they have to shift gears. They are more static than they are dynamic in their management and configuration. In terms of access issues, there's been a 30-year story with tax-funded systems of waiting lists. They go up, they get to a politically unsustainable level, efforts are made to reduce them more or less successfully, and then 10 years later you look and they have reemerged. England at the moment has over 500,000 patients who are waiting more than 4 months. This is after they have been diagnosed for elective procedures, and they still have some that are waiting a full year. That's not as bad as it was 30 years ago when it was 2 years, but this is one of the things that you will immediately hear about when you start talking to people about the National Health Service. Where they have real trouble, as I've said before, is cancer, and you'll see a number of slides on that, given the way in which cancer care has changed dramatically and 5-year survival rates have changed. And England does not do very well on that. There was a major initiative announced by the current national government in England, actually in the UK, about 3 months ago, in which they're going to make sure that everybody gets diagnosed within 3 weeks. But they always make these statements politically, and then the dilemma becomes how do you implement them in the policy terms, nuts and bolts, at the institutions. There's another slide about cancer. This is from Niall Ferguson, who's a Scot. So, of course, he's questionable talking about England. I mean, there's a slight issue there. Braveheart, you may remember. Nonetheless, he's a very senior economic historian, who wrote a really devastating piece that was in the Times of London 2 falls ago, in which he compared cancer outcomes, you can read them, in England as against cancer outcomes in the United States. And people are aware of this. This is one of the dilemmas, one of the current issues in the systems. When you look at Sweden, the Swedish situation is not as fraught as the English situation. Some of that is because of how Swedes themselves comport themselves, Swedish culture. But you find some interesting anomalies, some things actually that even in my case, having worked in Sweden for several decades, I wasn't aware of until recently. And it raises questions in my mind about some of the numbers for operating expenses, too. The notion that there's no adult physical exams. And then I started asking some of my other colleagues, Denmark, you get a physical exam as an adult only if you ask. In Norway, it was the same, only if you ask. And I said, well, how do you know, we're at Emory University, right? How do you know your numbers? Right? The whole notion about the importance of knowing what your blood pressure is, knowing what your cholesterol readings are, and being able to influence your health going forward. And they said, we have no idea. We don't know. So what percentage of health expenditure in the United States goes into that kind of exam? And if that's not part of what these systems in Northern Europe are doing, does that mean that their expenses are perhaps a little lower than what they would be if there were comparables in terms of delivery of services? And to what extent does that affect outcomes? Or maybe it doesn't affect outcomes because there are so many other factors that get involved. In terms of access, Sweden finally in 2005 introduced a guarantee in terms of access to specialists and then access to elective care. And that care guarantee is known as 079090. Very Swedish approach, very precise. 0 means that the primary care health center has to return your call the same day. That's a big deal to get the health center to call you back. It used to be in Sweden 30 years ago when you called the health center, if you could only call between 9 and 10 in the morning. If you called at 10:01, they'd say, I'm sorry, you have to call between 9 and 10, and they'd hang up on you. That was normal. That was how the public health centers operated. In this instance, the care guarantee is they have to get back to you the same day, 7 days to be seen by a specialist, which seems relatively normal in most systems. But then 90 days, 7 days to get an appointment with a specialist, 90 days to be seen by the specialist, and then 90 days after that to actually get the procedure. That's your guarantee, 6 months. Depending on the condition you've got, that is a long time. They've had all sorts of dilemmas and all sorts of variation in different parts of the country. The last point was something of a scandal because it was so extreme. 42 days to get back a breast biopsy. And that became a national story. I don't think that happens anymore, but that gives you a context, perhaps. Why is all this happening? Basically because there's been no real economic growth in most of these countries for the last 10 years, really since the 2008 recession, with some exceptions, but they're small exceptions in Europe generally and also the north of Europe. You'll see in a minute those numbers are going down. Secondly, they are trying to respond by improving efficiency, by, as I said, consolidating, restructuring levels of government. They've had some success with that, but perhaps not as much as they might like. There have been a lot of restructurings in these health systems, consolidating of institutions or restructuring the level of public governance, sometimes moving the level of taxation with it over the last 10 years definitely, but also it started really in the early 1990s, which is when they had an economic the first economic crisis in the Nordic world when the Soviet Union collapsed, because they had a lot of trade. But you can see that through this slide. And there are countries that are in the middle of trying to do major reforms and having great difficulty doing it right now. In Finland, the government, which is a coalition government, has nearly fallen, if you know that parliamentary phrase. In other words, the government loses the ability to maintain a majority in parliament and go to a new election. Over the health reform, multiple times, it's not clear whether or not, in fact, they're going to put this reform in place, which is consolidating and reconfiguring responsibility, giving the national government more control. Denmark and Norway restructured their systems, shrinking the number of county councils, pulling back the ability of lower-level government to tax back to the national government in order to have more control. They did that in the early 2000s. Norway made another set of changes around long-term care in 2012. I just read last week that Denmark, literally last week, has now just passed yet another consolidation at the hospital level in the health system. England is, you can almost argue, is permanently under reconstruction, the British National Health Service. It is a constant process. And it reflects, it reflects the fact that there's 1.2 million employees of the British National Health Service, and that they are centrally run. The joke in England is that the British National Health Service, or the English National Health Service, is the second largest employer in Europe. The first largest employer is the Russian Army. So that gives you some sense of the feeling around it. All right, I'm going to say a little bit more about money. I won't say too much because of issues of time in particular. You can check these things out yourself if you're interested. But essentially, there's been very low growth. If there's low growth and if there's low productivity and if real wages are mostly still falling, you don't have a base as a tax-funded system to raise more money from for your healthcare system, because taxes are what funds your system, and the taxes are tied to your economic productivity. So the last 10 years have been a real problem, and that shows dramatically in the fact that there's little new real revenues. You can argue that what's been going on is that industrial revolutions have consequences. We're in the middle still, as you're well aware, of the information revolution, and systems that were built for a previous economic platform have great difficulty in adjusting. They have to shift so many parameters, and that seems to be what the dilemma is, particularly with the tax-funded systems. The social insurance-funded systems are a little better, and particularly the Netherlands is considerably better. The Netherlands is kind of a bellwether. It is a social health insurance system, however, but it's kind of a bellwether for what's possible in universally funded systems which have less government involvement. So obviously, if you don't have public money, you can try and get non-public money, which is a polite way of saying private money, and there is some private money that has been drawn in, particularly in terms of out-of-pocket payments. In most of these countries, increasing numbers of middle and upper middle class people are buying private insurance, particularly around issues of cancer in Sweden, for one. In Finland, people buy private insurance for their children because they can't get access through the public health centers. So they want to be able to, in a sense, purchase access through the private side. 450,000 policies for children. If Finland's a country of 5 million people, I'm not sure how many children they have, but that's a sizable percentage. Okay, so that's your economic context, and then the question is, what do you do in terms of responding to the pressures you're under, all of the obvious pressures in terms of your system, and what one starts to see is that different countries are trying to adopt mechanisms that will solve the particular dilemmas they've identified in their system, but there's no pattern across all these systems. There's no one framework that you can point to and say, aha, this is what they're doing, beyond saying that they are trying to consolidate and restructure, which is a very general statement. If you look at hospitals, we talked about consolidating district into regional. That's a consolidating. Then there's a centralizing or re-centralizing of budget controls in a number of countries. There's also decentralizing budget controls or administrative structures, really, particularly to the municipalities for long-term care, and not just Norway and Denmark. England is talking about it. Sweden is trying to do it. Finland is going to do it now. So that is a broad category. Efforts to try and take health and social and find ways to get these two different activities to link better. And this has been a problem for 30 years. It's now become an acute problem. They are trying to find structural mechanisms as well as market mechanisms. They've got some very interesting market devices where if social care meaning long-term care and home care, if social care can't take back a patient from the hospital when the patient is finished, social care then has to pay the cost to the hospital out of the public social care budget to the public hospital for however many days that patient stays unnecessarily in hospital. Using a market mechanism, in effect, to link those two. Then there are a whole series of efforts, and we're not going to have time to go into the long-term care section, so the last 2 points here are useful. Essentially, pushing municipalities, requiring municipalities to put in place step-down beds, to monitor elderly who are dehydrated or who have known conditions so they don't end up getting to the emergency room, and in some cases putting municipal primary care units inside hospitals. I know in the United States we have a variety of different ways of utilizing primary care in hospitals, but this is seen as very innovative in the European context. There's also the whole question of waiting time guarantees. Allowing patients to choose private hospitals as well as public hospitals. And that now is true in England, Denmark, Norway, as an attempt to try to make care quicker and to put the public system under some pressure in terms of performance. There's all sorts of managerial efficiency mechanisms that are put in place. There's all these questions also about what's happening with long-term care. And here I'm going to move to the third part, which we've kind of introduced, but which I can show you a little more of. Perhaps we'll do a little bit of Norway and a little bit of the Netherlands, and then maybe we'll pause for some questions in terms of what's happening with these countries. Norway's gone through 3 successive reforms. One of the first things they did in 2002 was to take hospitals away from regional politicians and give them control to national politicians. That was seen as a major change. They also took away the ability of what had been regional government to tax, pulled that back nationally. So they centralized. They basically centralized control. But then they reorganized the hospitals as semi-autonomous units that were given more autonomy. This is another theme that goes across Northern Europe and Eastern Europe, but is always contentious. The politicians give control, and then they get unhappy with some of the results, and they typically pull at least some of it back. And there's been these shifts in various ways in which the ministry has dealt. That's the 2002. 2012, they put in place some of the long-term care reforms that I just mentioned in terms of municipal step-down beds, in terms of primary care units. They also made the municipalities municipal governments responsible for co-financing internal medicine and outpatient departments in the hospitals, to try to create a market incentive for the municipalities to not send as many people, as many elderly. And that's also where the fee came in. We've talked about the acute bed facilities. There's now actually a set of proposals in Norway still to get rid of the entire regional structure and just have the whole system run out of the national government, similar to the UK. So that they're not happy with the way in which these varying shifts have achieved the goals they're setting, so they're changing again. They're still trying to deal with the situation. I think the Netherlands may be an interesting place to pull this together and give you a somewhat different perspective. Netherlands is a complex system. I don't dare show you a chart. I'm off the mic. I don't dare show you a chart of how the system is organized. Suffice it to say that each individual pays a fixed premium to their choice of a sickness fund, and then there is a national government fund made up of employer money, which then also accompanies your payment as an individual to the sickness fund that you choose. What's very interesting about what the Netherlands has done is they have effectively said, we are unable in our social health insurance funded system to take care of everyone who needs long-term care, and particularly everyone who needs home care. We can't do that anymore. We don't have the resources financially. And out of that came, starting in 2013, a series of reforms that essentially sought, and at this point we don't know how successfully, in 2015 there were a series of legislative acts put in place which tried to move things back to municipalities. And you hear that word municipality again all the time in European context, municipal governments. They are different than municipal governments in the U.S. They're configured differently. They're designed differently. In most of the Nordic countries, they're designed to be a welfare agency. They were created in the 1980s. There's multiple dimensions on this. But what the Netherlands is trying to do is push things down to the municipal level and to the household level. And this is interesting because it runs against the grain of saying the system, the care system, has to do more. They're arguing it has to do less. And their approach is to shift to, maybe I can use the pointer, from professional care towards self-management, from specialists to generalists, from professional care to self-care. This is not a list from me. This is a list from the National Long-Term Care Institute in Utrecht. This is how they describe what is going on. Shift obviously from institutional care to care in the community. That is not so unique. This is kind of unique. This in the center, this is a diagram that the same National Institute put together to show the new structure of long-term care. This is the individual citizen, the person, the elderly person who is in need of support. And then the circle, the first circle, the green circle, which of course means good in the Dutch parlance. The green circle is neighbors, family, friends. That's who's supposed to support you first and foremost. And they actually have that written into the law, the 2015 law now, what's called kitchen table talk, in which the municipality is supposed to come in and sit down at your kitchen table and say, well, who can take care of you? Why do you assume we can take care of you? Very Dutch, very culturally Dutch. in terms of the hard-headed approach to it and straightforward approach to it. Nonetheless, that's what they have put in place. And then there are support agencies out here, and hospitals are way out here. They are seen as last resort. This is all driven both by the fact that elderly citizens prefer to be treated or taken care of as close to home as possible, but more importantly, it's being driven by financial and institutional incapacities. And this is the solution, really, that the Dutch have put forward. So pulling all this together, and I realize this has been a very rapid and a somewhat disconcerting tour because we're jumping from country to country, and there's not time to go into the specifics around it. But the dilemma number one is inadequate economic growth. That in turn has spawned an effort to try and squeeze more efficiency from existing resources. All sorts of things, re-centralizing, decentralizing, contradictory, combining, shifting, staging differently, wide range of different mechanisms. Not too much has been evaluated at this point, and certainly in terms of the more recent changes. It will be interesting to see the extent to which these shifts achieve their objective, or whether, in fact, path dependency, the structure of institutions, resists that. What you have, in effect, across the tax-funded structures in Northern Europe is a kind of structural uncertainty. They really aren't sure at this point what's going to work. And maybe that's a good place to conclude and leave the discussion. That was not what you were hoping to hear. I know that you came in here thinking that Denmark, that lovely little country of 5 million people, which is all the Danish population has, Denmark's population is smaller. We're back to geographical context here, the very beginning of the presentation. Denmark's population is smaller than the population of metropolitan Atlanta. Physically, it's somewhat bigger, but not a lot bigger. Sweden's population is 10 million people. So the country of Sweden has the same population as the state of Georgia. So when the country decides they're going to do something, and they're also culturally mostly homogeneous. Both those two societies still have a state Lutheran church, and in Sweden, half the population still pay a tax to the church, to the Lutheran church. It's not the same kind of configuration as what we look at in the United States, where if any of you have ever gone to the West Coast and looked back at the East Coast, particularly at Washington, D.C., your first thought is, gee, that's a long way away. Very different population size, geographic structure. We're also a federal system. These are primarily parliamentary, unitary structures of government, quite different. So hopefully this has given you a taste. I'm sure some of you have questions, issues that you would like to raise. Perhaps we can do that now. Thank you.
Thank you, Richard, very much. I'll open it up for questions. Given what's going on in Washington today about pharmaceutical cost and the negotiation about many of the countries in Europe have been able to keep pharmacy costs and negotiate direct contracts.
Correct.
Can you comment on that? Is that working effectively? Is that a model that we can look at?
I'm inevitably going to say yes, but. Or maybe as a proper academic, take a proper academic approach and say perhaps. Different countries in Europe do different combinations of elements in terms of trying to constrain pharmaceutical costs. Norway has a national formulary. The last I heard was around 2,300 molecules. And that also, by the way, actually it's not just molecules, it's molecules and delivery mechanisms, boxes, liquid, and so forth. They can do that because they're close to Netherlands and Germany, and if somebody shows up with malaria, they can fly in the drug they need overnight. That's their position. So they don't stock it. So if Norway's costs for pharmaceuticals are quite low, it reflects a constraint on the supply of drugs having to do with the uniformity, I suppose you would argue, of the geography and of the population. Not entirely, but mostly. If you look at the question about reference pricing, which is to try to pay in your country on the basis of a basket that other neighboring countries pay on, that works up to a point. But that creates a certain homogeneity. One of the reasons that it works in Europe is because Portugal has a considerably lower living standard and income level than does, for example, I'm trying to think of a country that uses that basket model, than say Austria. So by taking an average of what other countries pay, you're putting in what in some contexts might be called ringers. In other words, countries that are lower in order to pull down the average. And also, then there's a whole set of issues around what's called parallel importing. In England, pharmacists are very interested in importing drugs from Portugal because they can buy them cheaper and then reselling them at a rate in England. Because technically it's all one market. So how does that influence what goes on? Lastly, about England, and this is where the perhaps comes in. The British are very concerned, as are some of the other countries, Switzerland, France, Germany, with maintaining their manufacturing capacity in drugs. And they see it as an important part of their industrial policy. It's also export. They want to make the drugs in their country and then sell them abroad. So it's got a strong economic dimension to it. And in England, they have had in place now for 30 years, don't hold me to this, but I think it's PPRS. It's the name of the regulatory structure, but it is a profit-based structure negotiated every 5 years between actually it's not just England, it's the whole UK, between the UK government and each individual pharmaceutical company, in which they determine an allowable profit margin for that company. Typically around 17, 18% has been the number. And then as long as the overall payments to that drug company in England or in the UK stay within that ceiling, then the drug company can set whatever price it wants on new drugs. But then, and I'm going to have to stop in a minute, obviously. But then you have the dilemma that who's going to pay the new drug price if the new drug price is high, and then the new drugs often aren't carried, and then sometimes it got to the point in 2003 with Herceptin that individual citizens had to go out and buy it themselves as a drug, pharmacological for dealing with breast cancer. Individual women were going out and buying the drug themselves because the National Health Service wouldn't carry it. And then finally the Minister of Health, who was a woman, just said, this stops, we're going to supply. So are there differences in what they're doing in Europe compared to the U.S.? Yes. Are there models that we might adopt? Perhaps.
Good questions.
Sounds like a lot of effort shifting dollars from here to there. But on the provider side, really we're rationing. In other words, individual experiments eliminating pricing, procedures, very unpleasant and unpopular things.
Dialysis was not available in England to people who were over 60. They were told they had crumbly veins. This was in the 1980s. You can go read about it. There was a book written by a senior internist from one of the Boston teaching hospitals, Schwartz, I think. The word rationing comes with a lot of baggage. And they don't like to use the word rationing in Europe. They like to talk about waiting lists. But there are categories of care they don't get. And particularly with new drugs or new procedures, they're very slow on the uptake because it's complicated both in terms of staffing and even in terms of just training new internists and specialists in areas. And it typically produces a problem, often for 7, 8, 10 years, and then that problem becomes normalized. They basically are able to catch up with it. But then, obviously, medical technology has moved on by that point. So while your question is very appropriate, the dilemma is I would prefer to consider it in terms of the quality of care, the outcomes of care, and the impediments to access of care, rather than thinking about it in the context of a conscious policy of not providing people what is the clinical international standard of care, which is what the word rationing means. I hope that doesn't sound too evasive.
No.
It's just more complicated than that.
It's like passive euthanasia instead of active euthanasia.
I don't think I'm going to touch that.
Other questions? Rollins.
So, Richard, from what you said, it seems like in many countries people are combining buying private insurance in the market, but in addition to the healthcare, the government-provided insurance. Is that a trend that you're going to see more and more of people supplementing? I think about it like Medicare supplements or something like that. Medicare, Medicaps.
Yeah, it is supplemental insurance. It has always existed in Europe. A lot of companies provide it to their employees. It's an incentive for their employees. England has about 10% of the population in England has private insurance. Most of that is through their employer. It's part of the contract. Your speculation would presume that the public systems cannot measure up fast enough to what would be the expected international standard of care. And what I was showing you were some areas in these tax-funded systems where they don't measure up to the standard of international care, current standard of international care. That said, there obviously are equity issues with private insurance. There are there's political resistance on the parties of the left to private insurance that have to do with the inequities. So your configuration of forces is difficult. Nonetheless, the dilemma around private services is that demand will be there as long as the gap is relatively wide between what the public sector can provide and what can be delivered at the international clinical standard. And as long as that gap widens, you'll see more private insurance. Should it become possible for some of these tax-funded systems to close that gap? Maybe not. But at that point, you're not in the realm, really, of the healthcare system. You're in the realm of politics and economics. Yeah. That's hard to say. Restructuring around the edges, reconfiguring which level of government controls the hospitals is not a great improvement if you haven't changed the way the hospitals function and you haven't been able to supply them with what they need in order to provide adequate services. So it's not a one-for-one relationship.
Great.
Please.
I'm curious just about the prevention. So with nowadays compared to 100 years ago, with 90% of disease 100 years ago being infectious disease, and now it's chronic disease in terms of how people die now in Europe included, you would think that in countries that have healthcare that tax funded, the government will be more interested in implementing preventative initiatives that ultimately will help chronic conditions. Do you see any reflection in that or on that in your?
My colleagues in the European Observatory on Health Systems say yes, of course, and we've been doing it all. On the other hand, if you read the British newspapers, you'll discover that the British National Health Service last year decided that the only way they were going to be able to adequately diagnose the numbers of cancers in time, I guess you'd say, or at an early stage, they decided last year that they were going to actually buy MRIs and start positioning them in parking lots of supermarkets around the country. I remember that happening in the United States, but that was a while ago, 20 years ago maybe, that went on. So, yeah, are they doing prevention? Yes. Are they trying to improve the amount of prevention they provide? Yes. When the prevention involves various kinds of diagnostic procedures, it's more complicated. That said, you have a very extensive mother and child clinic structure in Denmark, Norway, and Sweden. Denmark is famous for what are called the district nurses, the home nurses, who come into your house when you come back from the hospital with a baby. And their job is to make sure that it's safe for the baby to be in your house. And if they have a sense that it is not, they take the baby. And that's still true in Denmark, and that's true for anybody of any income level, and that is still a big bone of contention amongst some of the political parties in Denmark. So do they do prevention? Yes. Have they done it for a long time? Yes. What do we mean by prevention? And then at that point, you have to kind of disaggregate and look at the different dimensions of it.
Mm-hmm. Thank you.
Thank you very much. We appreciate it.
Yeah, thank you.